Ahora, como colofón de todo esto, vamos a escuchar al doctor Jude Samulski, que es profesor de farmacología y director del Centro de Terapia Génica en el Chapel Hill University. Nos va a hablar de la terapia genética humana y la perspectiva en 30 años.
Is it working? Yes. Okay. First of all, I want to thank you for staying. I'm a fish out of water because I don't treat any patients. What I have in common with my colleagues is the commitment and dedication to finding cures for these diseases. I would also like to share with you that the future is around the corner. It doesn't have any meaning to a parent who needs something yesterday, but I'll try to walk you through what's coming with respect to the genetic revolution and the ability to exploit this at the molecular level. If I can get my slides to work. So, do you want me to do it? Just show me which button to push.
I have no idea, but I'm going to try.
Oh, then I'll try on my own. On this side?
So the one to the right.
Okay. No?
On the right, the dark, the black button.
Got it. You're looking at an image of a virus particle. And what I wanted to try to do was walk you through a scenario, and I wanted to use this movie that some of you may have seen and some of you haven't. The two things I learned from the previous talks is how passionate the researchers are, and Antonio made me quite aware how difficult when someone speaks in a different language it is to follow. So I hope you're able to follow my conversation today. This movie was about, they built a baseball field, and out of the cornfields came spirits that played the game years and years ago, and they came back to life. And it was a movie that basically was all about the passion. The next three slides I'm going to show you are basically a field of dreams. Technically, they won't make sense, but before the presentation's over, hopefully you'll understand what I'm talking about. We're looking at the ability to take a virus particle and target the brain, more importantly, target a seizure that may be somewhere deep in the brain and may be at different locations. We're looking at how do we do this without doing very invasive surgery. And so the procedure is to try to find a way to inject into the bloodstream a virus that will make its way to the brain and deliver genetic material to that disease area. This is done almost the same way COVID has spread around the world. And that is, the single virus that was responsible for COVID has mutated many, many times and has the opportunity to go through what's called evolutionary selection for a new virus. It may be Omicron, it may be the Delta. But through this selection, a new virus comes out that has properties that are totally unique compared to its parent. And so we made these libraries where we genetically shuffle the DNA so you get like a Rubik's Cube of information of these libraries. And then we ask the question, which one will go to the brain, which one will find the seizure? And so we injected into a rat, and the rat is 24 hours after the animals had an induced seizure. We go into the brain and remove the area that the seizure took place in. We isolate the DNA by a simple PCR technique. We clone it into a plasmid. We generate new virus, and we cycle it around and around and around until we find what Mother Nature has selected for a virus that will go directly to the seizure. And when we do that, we came up with a capsid that will cross the blood-brain barrier and go into the target tissue. Here's what happens. This is an animal that gets an electric shock, goes into a seizure. This is the animal that got the vector with an anti-epileptic gene. You can see when he gets the shock, and now there's no seizure. It's blunted the seizure completely. And so when I talk to you about this, what I'm trying to convey is a new technology that's coming to our clinicians with the ability to start looking at this, as Antonio said, all the different genes are being identified. We're fighting with insurances to do tests for these genes, but you can imagine a time where there will be a profile before your child's born. You'll know exactly which one is missing, and you'll be able to go in and try to alter it. I'm going to tell you about my experience, and it's been basically 40 years of working on the same problem. It's about gene delivery and gene therapy, but people don't realize that gene therapy was done over 200 years ago when Jenner vaccinated his own kid for smallpox. He noticed that the women that worked in the dairies that milked cows, they were resistant to smallpox epidemics. And so he argued that smallpox protected them. So he took the smallpox and he introduced the genetic material into the body. The body got educated, and then the immune system said when the real virus comes, it fought it off, which is where the word vaccine comes from vacuuming cows. And I'm going to try to walk through this fairly quickly because I know it's been a long day and you've had a lot of good science, and I'm here to tell your story. This story goes back to almost 1866 when Mendel saw the difference between a smooth pea and a wrinkled pea, and he said something's responsible for making this change. It was almost 87 years later we discovered the structure of this DNA, and from that we sequenced the human genome within 50 years of understanding the structure, so we know the entire blueprint of what makes us who we are. And this ability to go from an observation to something as detailed as this is illustrated better here. There's 3 billion nucleotides in our chromosomes that represent who we are. If you look at the Bible, on a single page there's about 3,000 characters, which would represent a nucleotide. And if you take the average length of a Bible, which is about 1,000 pages, it's about the same as having 1,000 Bibles worth of information to determine who we are and what's responsible. And I'm going to tell you something that's on my chromosome number 7. We have 1,000 books. On book 304, on page 347, on line 826, there's the following sentence. It says, "This is not a mistake." But I'm missing 3 nucleotides, and the meaning changes instantly. So now I have a mistake. I'm actually a carrier for cystic fibrosis. My brother's a carrier, his wife was a carrier, their daughter has a terminal disease. And so you can see that on average, everyone in the room carries about 3 to 5 of these silent mutations. My father, he died before he knew he was a carrier. But embedded in here is a simple mistake of which we're trying to correct. And I think Antonio explained it with some of the technologies that are being looked at today. So, there's over 100 new genetic disorders being diagnosed per year. When they find the gene, we now are coming up to the point where when you're born, you can almost see the complete likelihood of the life you're going to live. And the question is, how do we replace these genes? And I think, unfortunately, for the many parents that have children that have genetic disorders, this is typically the option they have. Is they have hope. There's hope that something's going on out there. It typically leads to some form of prayer, looking for someone to provide an answer. But what typically supports this is science. And I'm going to walk you through the history of how we got to where we are today. It's very intriguing. If you were living during the 50s, You may have remembered the polio epidemics. These were widespread, and they basically, entire society was shut down. It was because of this, they developed the first vaccine, the Salk vaccine, to prevent polio. And I was young enough to remember saving on Sunday where you got a sugar cube that had a polio vaccine on it. It was because of this miraculous event that they decided to start looking for vaccines. What caused the common cold? They found a virus called adenovirus. It was in the adenoids. And when they found this, they thought that they made a vaccine from that and no one would miss work again because they would have solved the problem. However, when they purified this virus, there was this little particle here that no one understood what it was. And for basically 10 years, it was not recognized as a separate virus. It was, in 1965, it was found out that every time you grow adenovirus, this other virus came along, so they called it adeno-associated virus, or AAV. It was later determined that this is a non-envelope virus, it's non-pathogenic, it doesn't integrate, and it carries a single-stranded DNA genome. Where did the hope come after that? It actually came from an interesting story where the National Cancer Act was put into motion by Richard Nixon, where they spent $1 billion trying to find out what caused cancer. And at that point, viruses were the things that people were using to demonstrate they could form cancer in an animal model. And the little parvovirus down here was basically the project that I was tasked to as a graduate student in 1970. God, what a good-looking guy. I always say this, I don't know how Brad Pitt got into my slides, but my job was to clone this virus into a plasmid so we could grow it up in bacteria. So let me take you into my world. We're going to go down and look to what can be put on the head of a pin. Here's a human hair at 2 millimeters. This is a bed mite. Keep going in magnification. This is a white blood cell, red blood cell. This is the E. coli that gets you sick when you don't cook your hamburger, streptococcus. And here is the ugly Ebola virus. But if you continue to go down in magnification, this is the AAV particle. And this is basically the virus that we took apart and tried to perfect how do we control this virus for delivering genetic material to patients. It had a very interesting life cycle. It did not cause a disease, but in the presence of adenovirus, it would hitchhike and generate copies of itself. But in the absence of adenovirus, it would go latent into your cells and just remain there. So if any of you had chicken pox, you're carrying the same virus that would cause herpes zosters when you get older. However, with AAV, if you get infected with adenovirus, it would go back into the lytic cycle. So we were trying to partition this into how to produce it and then how to deliver genes. So when we put this plasmid into human cells, to our surprise, we made virus again. So we actually had starting material. This took me to Princeton. Princeton took me to experiments that removed the AAV genes to put in foreign genes. The foreign genes were then developed so we could produce virus again. And then here's a very simple experiment. Instead of an AAV piece of DNA, let's take the gene that's in a firefly that glows, and let's put it in the AAV virus, and then let's put the virus in an animal and see where the virus goes. And when you do that, you can see wherever the virus is at, it's now glowing like the firefly. So this was the validation that the virus would be the cargo and deliver the cargo to the target cells. I went to the University of Pittsburgh where I got my first job, and I ended up showing that we could take this same gene and put it in many different serotypes like the flu, many different serotypes of AAV. And then you can see, depending on which serotype you use, it might be very good for going into the muscle, or it may not be good at all at going into the muscle. I got recruited at a very young age of 39 to be a director of a gene therapy center. Was that a great job? There were no gene therapy centers. It was who wants to be the leader here. We did a very simple experiment. We took a gene and we put it in the AAV vector, and we put it in the muscle of a normal mouse. And we did it at different doses, and then we left the animal alone. And what was surprising, a year and a half later, the gene was still there, suggesting that it mimicked exactly what happened in evolution. It would go into a cell and persist forever. This started what I now call the revolution of gene therapy, where different genes can be put into the vector, and the vector becomes a molecular FedEx truck. It's taking the cargo to the target site. This has now been published in many different journals for many different diseases. Let me show you one example where this was put into the eye of a dog that has a disease called Leber's congenital amaurosis. The virus is in the right eye. He can't see the worker until he comes in vision. Once he comes into his line of vision, he follows him. I don't know if you can hear this. This is saying the patient before bumps into the wall 14 times. It takes 77 seconds.
He bumped into obstacles 6 times and was disoriented twice. It took him 77 seconds to finish the course. 6 months after the treatment, the patient showed a dramatic improvement. He was able to make his way through the maze in 14 seconds without bumping into anything or getting disoriented.
So, for the eye, we now have a drug for this blindness that used to be in these children called Leber's congenital amaurosis. And this drug is available, approved in the US. It took 16 years from when we sequenced the human genome to be able to come back with a therapeutic. Don't lose sight of that, because we always get better and faster as things go on. Say that again. The next step we did was we finally got rid of adenovirus out of our production system, and we came up with a process that we've actually brought over here to our colleagues in Spain, and they have refined this to perfection in San Sebastian, where we now produce AAV vectors for many, many clinical indications. So this story about them coming out of the fields was actually recreated where the Yankees and the White Sox came out of the field to actually play a game of baseball. So the reality of a dream became real after this movie got started, popular. Here's the reality that exists today. This is our colleague Javier, our CEO Sheila McHale, and various important people in the Basque Country that have built a facility that's 30,000 meters. That's equivalent to 300,000, 90, tell me, what? 300,000 square feet if you are US. And this is done primarily to provide vectors for these gene therapy indications. In 2017, this was the team. Here's the team today with over 300-something people. These are the foundations that have started with us to help try to make this happen. And you can see most of them are just parents with children. And I want to show you, we developed a new vector because AAV was single-strand. We developed a new vector called a double-stranded AAV. And this was a more potent virus. You didn't need as much to put it in there. And we were able to treat Hannah's Hope, who had giant axon neuropathy. And Hannah got her drug after intrathecal delivery into the spinal cord, and it went into the neurons. And then we turned this into our colleagues that were working on what's called SMA, spinal muscular atrophy. And this one, they're called floppy babies because they're missing a critical protein that's made by the SMA gene. Here's our colleague here after being treated. 2019. Much, much faster. So, because of the power of this, there's also the risk that patients won't get access to it because it costs too much money. So the colleagues here in Spain, with our dear leader here, Sheila McHale, started a foundation called the Children's Foundation. Chris Bankiewicz is a neurosurgeon, and what Chris did was he took on a very horrific disease after we performed in 2002 the very early studies of delivering AAV into the brain for Canavan's disease. Chris then replaced the Canavan gene with amino acid decarboxylase. And this is a disorder referred to as juvenile Parkinson's, where the patient is not able to make dopamine. All the structural components are there. So Chris took the vector, injected it into the substantia nigra, produced the amino acid decarboxylase that made dopamine, and this is the patient on baseline. You can see that almost all activities have to be performed by the caregiver or the mother. This is basically 18 months later. She's dancing on the couch. I draw your attention to her sibling over here who eggs her into dancing when he starts moving his shoulder like this. Watch the interaction. She picks up on it right away. And starts doing her moves. And then over here you can see 24 months later she's not only participating, she's making gestures and things of what she likes and doesn't like. One virus, one injection for life. So I'm going to end by letting you know that this was not published by an academic. It was not published by a company. This was published by the FDA that said they anticipate by 2025 10 to 20 new gene therapies becoming available to the community. So think about that. Almost 100 years ago, from something made a pea smooth the wrinkle to the structure to the sequence, all of it based on a virus epidemic like COVID that forced us to go down a path to understand why these viruses cause these problems. And I think what I would like to impress upon you is within 60 years it's been determined that kids born today may live to 142 years of age. Now, I don't know about you, if I'm going to live that long, there needs to be some repair going on somewhere. But I want to just impress upon you, over history, we have made contributions that are significant. Everyone recognizes this before you say a word, and you understand what this, and you know the importance of this. And what I would leave you with, it's a little story about what was called the spruce goose. Some of you won't be familiar with this, but Howard Hughes was a famous millionaire that got a military contract to build the largest plane ever. He was going to send over equipment like tanks and trucks during World War II to help supplement the war. And he got called in front of the Senate because it was costing so much money and it wasn't getting done. And he said he spent more of his own money than the government money because he had a dream that if you build it, people will come. And so he got this thing to fly only 35 feet above the water for like 12 minutes, and it never flew again. It's now a museum piece in the San Diego harbor. But what I leave you with, it's one man's dream, it's another's reality. Thank you. Sure.
Can I have the first question? So do you have this therapy for every gene mutation? Can I tell you my gene mutation? This is working with everything?
So I think what you're going to see is the next drug to be approved will probably be a hemophilia drug. After that will probably be a muscular dystrophy drug. And then there's a cascade of them that are starting to come into the clinic in the FDA. More for blindness because of the success in the eye. And I think what's happening now is there's a tremendous interest from the pharmaceutical company because if you think about it, this was an area that was basically, they couldn't develop anything that really worked. And so now they see it as an opportunity to finally bring something to this community. I see the genetic revolution basically displacing small molecules over time. As Antonio said, once you know these genes and the networks and what's happening, you'll be able to go in and tweak them to perform at the right behavioral that's expected. So it's Star Wars to some people, but it's reality to those who are marching down this path. Thank you. Well, I put everybody to sleep, so there's no more questions.
Hi, good afternoon. My question is, if our child is affected genetically, right? How can we make good use or proper use of this genetic medicine if every single cell of their body is affected by genetic deficiency?
Yeah. So as you can imagine, we're looking at some diseases that happen as you develop and some that are at very critical and very first stages of development. And obviously, things that are important and early in development means you have to intervene much earlier. Rett syndrome requires intervention before the third trimester in order to get the networking. However, if you are dealing with something like hemophilia, there's protein products you can take and then eventually put the gene back and you're done. So I think a lot of this is going to depend on what is the mutation, what are the symptoms that are caused by it. What we're seeing in the clinical setting is the younger the child, the more benefit that they experience. Obviously, as you would imagine, you prevent some of the things that I think Dr. Wolf and our colleagues from the U.S. were speaking about. The sooner you intervene, the better you are at all the cascade of other things that are happening. I don't think we're at a point where we can do in utero gene therapy. Our colleagues in China tried that on a CRISPR, and he disappeared. So we really don't know what happened in that. But I think what it was an early effort to say, if we can manipulate at this point, we can really prevent mutations from coming through that may be somatic and not passed on in the germline. I hope that makes sense.
How can this technology be used to work to antagonize any infection from any bacteria or viruses?
Oh, yeah.
So if you have a viral infection, how can you use this technology?
So David Baltimore coined a phrase called molecular immunology, where, like Jenna did with the vaccine, his argument was you can go in and technically change the receptor that viruses use to come into the cell. So you may or may not be familiar that when there's an outbreak of flu in the chip and poultry industry, they cull the entire group. But you could genetically alter them so the flu can never infect them again. And by doing that, you remove the protein that lets the virus gain access, and they become immune or resistant. And so there's a lot of hypotheses about how one can start to improving your immunity, not just by antibodies and B cells and T cells, but at the molecular level, make you resistant to various infections, including COVID. Antonio's going to ask me a hard question, and I'm not going to be able to answer it.
Well, I don't know if it's hard, but we had an argument with some colleagues whether new vaccinations using adenovirus would eventually make some people resistant to gene therapy with adenovirus.
Okay, he brought up a really brilliant and obvious question, which is, your immune system is going to fight the gene therapy the same way it fights a normal infection. And then how do we end up being able to treat someone if they already have immunity? And the chances are, in this room, there's a number of us that carry natural antibodies against AAV. So there are many, many groups out there working on that. In fact, there's groups that have already come up with an enzyme that will cleave antibodies and cleave them apart. So what you do is you give them the protein, it chews up the antibody, you give them the vector, their antibodies come back, but the gene's already gotten inside the cell. And so there are clever ways of trying to dodge the immune system. One is a simple one that's used every day called plasmapheresis. They simply take your blood and put it through a column, and it pulls out the antibodies, and then they give you the vector. So there are many ways to do it right now. They're all experimental. But I would say that's probably not our biggest concern, you know, with respect to repeat administration. It's probably going to be more about regulating a gene that may be really sophisticated instead of just on or off. It may need to be on at nighttime, off a little bit in the morning, things like that. Those are going to be tougher problems. Okay, you got to stop the thing.
And is it possible to know if in some time it will have side effects?
Oh, yeah, perfect question. What is that virus doing? And these experiments we're putting in millions and millions and millions of viruses. Our immune system's very good at getting rid of most of them. The ones that get in are just now a piece of DNA. They don't have any viral components. So they're just persisting. Like if this light bulb was out, you just replace the light bulb. You're not replacing the whole circuitry. So at the moment, the risk is one of evolution. We've been carrying this virus. We didn't know we had it for thousands of years until 1953. We didn't know what it was till 1965. We didn't know what it did until 1978. And so we're really going backwards and trying to find out. It's more like the symbiotic relationship that you see between the sea anemone and the clownfish. The two coexist, but we don't understand what is the benefit or the harm. And this seems to be one of those relationships where AAV is a molecular hitchhiker that gets into humans and it jumps off and rides with adenovirus and gets into the next human. So at the moment, it's a non-pathogenic virus that seems to coexist with humans. Really good question.
Well, thank you very much.
Thank you.
Thank you.